Welcome to another episode of Health Matters. My name's Heather, and this is PA Lynn Szabo. What are we going to talk about today, Lynn?
Urinary incontinence in women.
Oh, that's a fun topic.
Well, it's a topic that should get more attention than it does because it causes incredible shame for women.
Yes.
And I've actually in my career see it contribute to death from a resistant bacteria that was due to antibiotic misuse.
Oh, wow.
Yeah. And so women don't want to talk about it. They get marketed to a lot for, this and that. But it needs to be addressed in a coherent medical way because it's a complex topic. And frequently doctors don't want to take the time to understand it or to deal with it. And women don't want to talk about it because they're ashamed of themselves. So super big quality of care issue, super big quality of life issue.
Yeah.
So this talk is directed to women, but I've also recently seen a man who was affected by it. So it affects men as well. So what is it? What is urinary incontinence? Well, it's the involuntary, spontaneous release of urine at inopportune times.
That's a bit of an understatement there.
Yeah, no kidding. And there are two types.
Inopportune.
There are stress incontinence, and then there's urge incontinence. So stress incontinence is like if a woman coughs or sneezes or laughs or any time that she does what's kind of called a valsalva, which is increases her inner abdominal pressure, sometimes urine leaks out.
Okay.
And then urge incontinence is kind of like you got to go right this second, right now. You don't have enough time to get to the bathroom, and you're already peed yourself.
Okay.
And oftentimes people have kind of a combination of both. It can be
And this isn't all the time thing?
It can be.
Okay.
It can be. It's a little bit better if your bladder's emptied, but it's also kind of part of this is your bladder never really empties completely.
Oh, geez.
And that causes, of course, risk for infection. So risk, let's see, it can be caused by muscle problems, connective tissue problems, and nervous systems problems, but it's probably the whole ball of wax.
Okay.
Probably a little bit of everything.
It's a complex, compounded little things.
It is. That's why it takes a while to kind of tease out, and that's why I think providers don't really want to spend the time. Women in general, I'll just speak to UTIs because I've heard this recently too, get shamed a lot for not wiping right, and that's something that contributes to universal urinary problems. And that usually comes from doctors or providers who are in a big hurry and they just want to cut to what they think is the chase. And spoiler alert, they're wrong. Or in the case of the last patient I heard about, she was being talked to by a medical assistant who didn't know what she was talking about. And this woman was deeply shamed.
Wow.
Because she was told she wasn't keeping herself clean enough, which was utterly ridiculous.
Jeez.
So risk factors can include pregnancy with vaginal deliveries. So that's like
Risk factors for the UTI or for the incontinence?
for the incontinence. Okay. Increasing age, obesity, and then also neurologic issues.
Okay, so something that most women will face at some point in time.
Yeah, and I want to kind of throw this in here, but I took care of a woman through urgent care at one time who was denied care at one of the local primary care offices because she was incontinent. She was an elderly woman, and because she smelled a urine.
You're kidding.
And they didn't want her in the waiting room, and so they dropped her from the practice. And
instead of addressing the underlying health issues that caused the smell, they just decided to kick her out.
Totally.
Wow, that's disgusting.
And
that is absolutely vile.
This is a huge thank you to Dr. Chris Cutter, who was in town at the time. And I said she doesn't, she's like almost 100 years old. She's pretty clear, but she's wheelchair bound. And now she doesn't have a provider. And he said, she can be in my waiting room without fear of consequence.
See, I loved him. He was my doctor, too.
Yeah, he was awesome.
He really was.
Yeah. come back. Come back.
He ain't coming back. He's having fun down there. We're still friends on Facebook.
All right. Well, how is this evaluated? So there's lots of urologic testing that I was reading through, and I won't get into detail about it.
Thank you.
Some of it's scary. And then, of course, it can be done, and this particular testing can impact management. But of note, I have not really met very many urologists that are interested in treating this. In fact, almost all of the urologists I can think of in 3 counties, it's actually 2 counties because we don't have one, are really not interested in dealing with urologic problems that women have.
Why?
Of note, they're all men. Okay.
Oh, yeah, that explains why.
And so most of the care comes from gynecologists, with a focus mostly. It's seen as a possibility to do surgery, and that they don't really order the urologic testing because they're not trained for that, and that's not the focal point of what they want to do.
Is this one of those things, if the only tool you have is a hammer, everything you see is a nail?
Yeah.
Okay.
So this is
So we're not getting care for this.
This is kind of an orphan disease because women don't admit they have it, and providers don't really want to treat it. But there's a lot of things out there that are actually could be helpful, and I was surprised by some of them. But we'll get to that.
Okay.
Okay. There is, however, kind of a faint hope. There's an increase in care from specialized clinics that are established. I think there's one in Medford. They are not easy to access from here, and I imagine other rural communities have the same problem. And one of the biggest problems after not knowing they're there, not knowing that's the place you should go, is the usual insurance barriers to care.
Okay, so you mean like a urologist? Just go see a urologist?
Now, these are specialized urogynecologists.
Oh, I've never even heard of such a specialty.
Right. But the problem is, let's say you're on partnership and you're living in Northern California, then the problem is that you can't get to Medford where the care is, and you can't really get to UCSF where they have similar care, because it's hard to drive down there, it's hard to stay down there, it's hard to get the referral to know that you're spending all that effort to go down and actually see the right person, or are they just going to say, no, I don't do that, and not be helpful.
Yeah, that actually, sorry, we're going to like little squirrels here, side quest on that thing. Maybe it would be a really good idea to do a longer episode one of these days about how we do access that care for the people who are on partnership here in Delaware County. And then how, if you do need to see that specialty, how we can get that, we can get that taken care of, because there is a process, there is a way, and then there is a way to get reimbursed for gas mileage or to get prepaid for those things and meals and a hotel.
Somebody to actually drive you down there,
or get a taxi driver to take you there and back.
A car that's not going to make it.
Yeah. So there's other resources and things too. So I think that'd be a good episode to do. And then partnership is always willing to reach out to those doctors and those specialties that we need here in Del Norte County if they're in Jackson or Josephine or Curry County, so that we can access them.
Let me just say, as a provider in both the UIHS and the Del Norte Community Health Center systems, I had no knowledge of what you just said. We have no working knowledge of that.
Wow. Yeah. Okay. See, this is a good. Maybe we do a live, community-based, in-person, town hall style Health Matters one of these days.
I'm down.
All right. Okay. Go ahead. Sorry.
Okay. But oftentimes the easy go-to solution is women get told they need to do Kegels. And every woman out
Why
there
is that
knows,
the solution to everything that's wrong with a woman?
Yeah, do Kegels. But here's the problem.
I didn't sleep good last night. Did you do your Kegels?
Yeah, there's no real discussion about how to do a Kegel. Oftentimes, if you're talking to a male, I wouldn't expect them to know how to do it or how to teach it. But they also leave out the part where you have to do like a couple hundred every day.
Oh.
In order to get a significant response. And
are you going to teach us to do Kegels right now?
Yeah, we could be.
You could do whatever you want to, Lynn. It's your show.
Well, maybe so. But the way I say is, so I give it in detailed description of how to do it. And then what I say is, like, divide it up. So do like 10 every time you're at a traffic stop, do 25 when you're doing the dishes. Okay. And that's much more manageable for people. But I think the failure rate of doing Kegels is like 99.9%.
What do you mean failure rate?
That people don't do them because they don't know how to do them, and they don't know that they just don't have lives where they need to do, they're able to do that much. Because the look on their faces when you say, well, you have to do about 100 of them, they just look at you in utter like dismay. So there's also medications that you can take, but if you don't really know what kind of urinary incontinence you have, it's hard to know what's going to help. And some of these medications have side effects that are of concern to people.
What do you mean, what kind of incontinence? Do you mean like the stress-induced or the urgency?
Stress or urge. Or is there a neurologic component, or is it more muscular? What are the cofactors, the comorbidities? So since the differential diagnosis is long, it makes sense to focus on the diagnosis. Clarity in diagnosis always leads the way for treatment.
That makes a lot of sense.
They're going to write that on my gravestone. But so there's...
You're not allowed to die, Lynn. You have to stay with us forever.
I know. So there's treatments, they start with the usual ones, and they never really go beyond these. But these are things like lose weight. How can you do that? They just took the Ozempic-like drugs, the injectable weight loss drugs, away from a lot of people who, by the way, are in super freak-out mode about it. And there's a lot of sadness and anger because they're being told that if they just ate better and did more exercise, then it wouldn't be a problem. And we all know that's not true.
Yeah, stinking Barack Obama.
Yeah. So lose weight is an important treatment.
That was sarcasm for people listening at home.
I know. Decrease caffeine, decrease fluids, and stop smoking. Okay, those are all the usual ones. Some of them are harder to do than others. Some of them are virtually impossible.
Okay, I have a question. Yeah. So I thought we were supposed to drink more fluids to help keep UTIs away.
Yeah.
So this is, oh my gosh.
That's my next sentence. I was going to say, like, what? Because you told me to do this, and now you're telling me to do that.
Yeah, drink more water so that you stay hydrated so you can keep the UTIs away, and then you have all of these other issues, right? You don't get constipated, and then drink less water so you don't pee yourself.
Right. And so we'll get to that. Constipation is actually, I'll just say it now, there's new focus on treating constipation. So constipation has seen... our understanding is now that constipation can kind of cause, over time, cause a laxity in the pelvic floor. And this causes women to have more problems with urination. So if you're drinking more fluids because you're constipated, or if you're constipated and your provider says, well, just have some caffeine, a cup of coffee should help that, then you're really going in the wrong direction. So what's a poor Del Norte woman supposed to do? They'll tell you to do Kegels. We talked about that. And they might suggest pessaries. So pessaries are kind of a support structure for the inside of the vagina, and it kind of hoists everything up.
Okay.
And I have seen, in 40 years, I have seen 2 women that had them.
Okay.
So not super common.
I think, is that because they're not effective or because we're not aware of the treatment?
They're uncomfortable, and women don't like wearing them.
Okay.
Is what the problem is. And then there's also biofeedback. So where does one even get that in Humboldt County? I have no idea.
I have no idea either. What is biofeedback?
Biofeedback is a way to become really aware of certain body mechanisms in order to kind of focus relaxation in a certain direction. Like if somebody was having a panic attack, a biofeedback mechanism for treatment would be to focus on lowering somebody's heart rate. And you can do that. It is to a certain extent controllable.
So is that like a mindfulness exercise, or is this a medication?
Yeah. And well, it's a mindfulness exercise coupled with kind of an electrophysiologic teaching program.
Oh.
So you have to have specialized equipment.
Okay.
And it was kind of big in the 70s. College of the Redwoods actually had a class in it, and it fell by the wayside, and now access to that kind of care is virtually impossible.
Is that because it's woo-woo, or is that because it worked and therefore it didn't make money long term,
Probably
so we had to
both.
stop?
Probably both.
it's
So the other new focus for this, and women need to pay attention to this one, is one of the treatments is actually using topical estrogen cream. And I prescribe this all the time.
I was going to say, everybody I've ever heard talk to that's used it swears by it.
Right.
Like, no, get your doctor to get you this. It's amazing.
Right. It's useful for a couple of things. One is it makes sex more comfortable for an aging vagina, which is can be important. It may be in a relationship, but the other thing that it does is it kind of makes the health of the surrounding tissues improved, and that helps with urinary incontinence. That helps with vaginal itching, vulvar itching, and burning and things like that. Okay. So it's more important to kind of vulvar. I'm using vulvar to describe the external part of the female genitalia. The vagina is the internal part. So women talk about their vaginas, they usually mean their vulvas.
Okay.
So I prescribe it constantly. The barriers to getting it are to get women to believe it'll help them, because they don't really want to use it.
Why?
Because there was a lot of talk about 20 years ago about estrogen cream, and it scared people. I mean, not cream in particular, about Prempro, which is systemic estrogen progesterone pills. Yeah.
But this is not that. This is a vaginal cream.
This is a topical.
Okay. And then does it just stay there locally, or does it get like into your bloodstream and go everywhere?
It does go into the bloodstream a little bit, but not to the extent that it's going to be a problem in other areas. In fact, I've been to women's health conferences where they say topical estrogen can be indicated in even women with breast cancer, although I think you have to get clearance from your oncologist on that, because that probably depends a lot about what kind of breast cancer somebody has.
Okay. That would make sense. That'd make because there's a gazillion little different nuances with that kind of stuff, and we know those things now.
Yeah, and it's expensive, and insurance doesn't like paying for it, and I don't think it's FDA approved for necessarily for urinary incontinence, although it should be. And so insurance throws up a lot of barriers to its use.
So that would be an off-label thing if you're using it for an incontinence.
I think, yeah, it could be considered that.
Okay.
And the true word on this is that pharmacologic efforts to take care of this problem are way less effective than lifestyle. But here's where my mind was blown. There is some suggestion that pills like pseudoephedrine and duloxetine, so Sudafed and Cymbalta, are recommended as well to treat this. I have zero knowledge of this.
Wow.
My mind was blown when I was looking in my little Hippocrates to learn more about it.
Is this an update since January of 2025?
Probably. Probably.
So is it accurate information? I mean, because now we're told Tylenol causes autism. So, I mean, is this...
This is from a medical source that I believe to be...
that's not been corrupted?
Has not been corrupted. This isn't the
That's all I wanted to know. Sorry. I didn't know how to say that nicely.
Well, they use generic terms for drugs and not...
No. I just wanted to make sure that it wasn't Kennedy in there saying, hey, did you know?
He doesn't have a vagina. I wouldn't listen to him about anything. All right.
Maybe if he did have one, we'd have some intelligence.
So the next thing is there's surgery like slings and hysterectomies that can help. And that's mostly what gynecologists do best. And so if you were a woman troubled by this and you went to see your usual gynecologist, they would immediately jump to surgical stuff. That's why the two specialties of urology and gynecology merging is such good news for all of us, because they can expand their knowledge, and they actually have whole clinics. So they have the biofeedback stuff. They could do the testing.
Oh, that's good. Mm-hmm. Well, it would be nice to have a whole comprehensive medical health for us as women.
Yeah, I agree. There's also a lot of treatments in Europe that are not available here. And so this is where we might have problems, getting access to this kind of care.
It's data supported care, or is this not data supported care?
Say that again. What are you really asking?
Is this scientifically proven health things in Europe that we just don't have access to here?
This is data driven.
Okay.
Yeah. So European women have it better. So these treatments.
Yes, they do. They really do.
I know. This is like, think about how cosmetic surgery does lip surgery and does fillers to plump lips up. Okay.
So you're going to plump the other lips.
Periurethral bulking agents are injected around the urethra or the bladder neck to tighten these structures up and make them less leaky.
Okay.
And I did read actually a testimonial, I guess. Actually, it's just an article in The Guardian about a woman who had this done. Now, she lives in Great Britain, so she was going outside of their National Health Service and
Okay.
was going into what they would call private practice. And after years of being kind of humiliated and having treatments that didn't help her at all, she had this done, and it was life-changing.
Wow.
Yeah, absolutely life-changing. And the thought is that, like, getting your lips done, you got to get your lady parts done on a kind of regular basis.
Just for the record, Lynn, if you start having those house parties at your house, I don't want an invitation to that one.
Right, exactly.
There's no Botox parties for Lynn's house.
So what's the average Del Norte woman supposed to do?
I have no idea at this point.
Right now it's mostly exercise, weight management, pelvic floor exercises, which are Kegels.
Wait.
But do the Kegels around childbirth.
So pelvic floor exercises are just Kegels. That's it.
I don't know of any other ones, but there
Then why do we have physical therapists that specialized in pelvic floor exercises?
do. There's one in Humboldt in the UIHS
No, they're
system.
closed.
Yeah.
No, they're gone.
No, in the UIHS system.
Oh, I thought they're
Uh-huh.
okay.
But if you go, like Yoga with Adrian has a pelvic floor kind of practice that addresses it. There's apparently a yoga move called skull scraping. That sounds scary. But
All right, now I got to Google
yeah. So
the things I learned with you, Lynn.
I know. So doing that around childbirth is important, both before and after deliveries, and then try and reduce things like need for episiotomies and things. So maybe gentler births could help with this. And but the big one a woman has control over is constipation control, and a lot of people don't even realize they're constipated. So if your doctor says, well, I'm looking at this x-ray of your abdomen and it looks like, you got a problem here, you should probably start drinking the prune juice, believe them and do that, because constipation control over time is probably one of the most important things you could do, actually, as you're a woman kind of going through your life and aging. And this is a way to prevent the setup for this problem. And kind of interesting, in my research, they said long-distance runners, women who are long-distance runners who are young, it's the ultra-marathoners, the long, repeated kind of pounding on their pelvic floor can set this up.
Oh wow. Okay, so so no running. That's not good. So do yoga. Mm-hmm. Tai Chi.
Yeah. If you're a long distance runner, then be mindful that you could be setting yourself up for this long term.
Okay.
Okay.
Well, I don't know why anybody runs anyway. It's bad for your knees. You break your feet.
I wish I could. I would love doing it. Anyway, there's more interest in treating this problem, which is super hopeful.
Yeah.
In the meantime, if your provider has given you a plan of treatment, then follow through. Pay attention to your constipation. Pay attention to prescriptions like topical vulvar yeast applications. Make sure you follow through with them. I actually tell women the instructions that the pharmacist insists on is to use the cream intravaginally, but I think it's more useful if you use it on the vulva instead of the vagina. So externally, just put a little on your finger and get it to where it needs to go. This is an important lack in women's health care. And I really want to say to women, take it seriously. Not only are we humiliated by it, but also it affects our lives. And some women in my personal patient base, actually, one woman actually had an uncontrollable infection that she ended up dying from because this wasn't treated correctly. She had a misunderstanding of what was wrong with her over decades of her life, and it led to an unnecessary death, in my opinion.
Wow.
Yeah, really horrible.
That is.
Yeah. So, we could talk about it, especially we should talk more about the barrier to care thing.
Absolutely.
Super frustrating.
Well, since we're here, Tom, we're talking about it anyways, and we have a few minutes left. You were talking about UTIs and how we're told consistently, like it's from not being clean or not wiping properly.
Right.
What is the primary cause for UTIs, or what are some of the causes for UTIs?
Constipation, misdiagnosis.
What do you mean misdiagnosis? They say it's something else and not a UTI?
Right.
Okay.
And women oftentimes will come in and they'll say they have a UTI, but then the provider needs to say, well, what symptoms do you have? And a lot of women are like talking about abdominal pain, and they don't really have a UTI. They really have gallbladder disease or something. I mean,
Okay.
It goes wildly off track because women they're not ignorant women, but they've been educated to think that every problem that a woman has is a UTI, and that's not necessarily it.
Yeah, that's everything. Is always it's
Right.
It's a UTI.
Right. So, there is going to be a lot of diagnosis and treatment of UTIs over the phone, which is good in one way, but they're using guidelines that have been okayed since 2010 by the Infectious Disease Society of America. But this is going to lead to a certain percentage of women that are overtreated. So talk about your symptoms. If you're a patient, don't go in with a diagnosis. Tell me what your symptoms are.
Okay. Can't we? If you go in and you say you think you have a UTI, don't they usually just make you do a urine test?
Right. So the
And then culture
current
it?
guidelines of the Infectious Disease Society of America, which have been in place 15 years, say the urine dip is the least important piece of information that a provider should rely on. And providers in the rest of the world have agreed with that, but in Del Norte, they don't.
Okay. So a urine sample is not the most important diagnostic tool.
No. It's what the woman tells you.
Okay.
And as a patient, if you want to maximize that, then you have to say things like, it hurts when I pee. I'm peeing more often than usual. You don't say things like, well, my stomach vaguely hurts.
Okay.
And
this is one of those things too, where past traumas for a woman and all of those other things, and being nervous, and that's because I get nervous going to the doctors. I have to have a relationship with my doctors,
Right.
and that takes years to establish, and then they
get
move
it.
away, and then I have to do it again, and so it's a scary process.
Right.
So when that happens, I mean, because you're a provider, right? And I'm a nervous patient. How especially for somebody who's younger, how do you tease that out of them to actually tell you? Do you have to ask them, does it hurt when you go to the bathroom? Does it hurt over here? Can you tell me all of your symptoms? Is that all that you're experiencing?
I ask questions and I do exams, and I'm told that's unusual. And
It really is.
but that shouldn't be unusual. That should be the thing.
It is. But right, you've talked about it before too. You have 7 minutes. So if somebody comes in there and says, I think I have a UTI, and then because that's what their mom said or their
Right.
aunt said or their
Right.
best friend or the
Right.
medical assistant you were talking about earlier
Right.
doesn't know what they're talking about said. So
I don't stop there. So what do you mean? What do you mean?
Okay.
What's your symptom? And some people take that as challenging their knowledge about their body, but it shouldn't be. It's about getting more information so you make a better diagnosis. And it's always about the differential. And the diagnosis sets the treatment. So if you don't have an accurate diagnosis, it's a waste of time.
all right. Well, that's good to know. And I thank you very much for keeping it old school and actually treating the patient and not just billing.
Exactly.
Because that's essentially what is taking place now when we go to the doctor. All right. Well, that was a stunning conversation there. I appreciate that very much. What are we going to talk about next week?
I'm kind of obsessed about prostate cancer screening because that's a hot topic right now for men.
Turn your head and cough. All right. So next week, we will turn our heads and cough. Thanks, Lynn. I'll see you next week.
Okay.
Bye-bye.
Bye.